Good morning, good afternoon, good evening. Happy holidays, everyone. It's our neurology VMR holiday series with last week and then today, Christmas Eve day, and then next week, New Year's Eve day. So nice to see all of you who like to celebrate the holidays by discussing or learning neurology. That's how we do it on CP Solvers. Um, so we have the all-star team here. And if someone wants to get the whiteboard up, I think we can go ahead. And we do have there's another group coming at 10, I think. Is that right today? Oops, did you lose me? There is another group coming at 10 today. So we just have to be mindful of the time. Don't give anything away, but if I'm diving too deeply too soon, if there's feel free to guide me that we should move forward so that we finish by 10 o'clock and be respectful of the next group. Okay, any other orders of business to discuss, or shall we go ahead and get started?
I think we're ready.
Okay, great. Why don't you tell us the chief concern?
All right. So the chief complaint is 73 years old male presenting with sudden onset of diplopia, double vision.
I think we lost Aaron briefly. Aaron, you're there?
Yeah, I think my internet was just went out for a second. I'm back.
Yeah, I can
Okay,
hear you perfectly.
let's try this again. Okay. Would you like to go ahead and give us the chief concern?
Yeah, so the chief complaint is 73 years old male with sudden onset of double vision or diplopia for 1 day.
Diplopia, double vision, fantastic. Okay, Vale, how do you think about double vision?
Yeah, I think diplopia is one of those things that I've learned to love because of you and the whole Neuro VMR team, because otherwise it will be very intimidating. But I think to start with diplopia, first, I think if it's ophthalmology problem or if it's a neurological problem, meaning my problem, meaning that if it's monocular or binocular diplopia. And just to kind of settle what diplopia means, for me, it immediately translates to a misalignment of the eyes. So something that connect or coordinates the movement of the eyes is not working well. And this could be something pre-orbital, something that ophthalmology knows way better than me, like a refractive error or something. It can also be something structural happening in the orbit itself, like a mass or something that, as a neurologist as well, maybe I'm not so familiar with. But then we can also think about things that are affecting the nerve and then going all the way down to the brainstem, where the nuclei of the extraocular movements are, or the nerves that control the extraocular movements are. So, okay, so anything in the orbits that could be compressing the nerves and they're kind of the way that they go out of the skull, something like a mass, or even in well, this is more like the muscles that are itself moving the eye, but like a thyroid disease that could be kind of getting the muscles very thick, and so they're not moving that well. And the muscles that I'm talking about are the ones that are innervated by the third, the fourth, and the sixth. So those are the nerves that I need to be mindful of. All of this assuming that this is binocular diplopia, by the way. um, and then these nerves go through all the way through the cavernous sinus. So any disease there could also be affected. And clues are also the compromise of the fifth nerve, so the sensitivity of the face. Then they go all the way through the base of the skull and get to the brainstem. And in the brainstem, we know the rule of fourths, so usually are in the pons and above, also considering the midbrain. So yeah, I think that's what I'm thinking about. Well, also I don't think I mentioned like neuromuscular junction, which will be the bridge between the muscle and the brain and the nerve. And in that case, a never misdiagnosis will be myasthenia gravis. But yeah, that's kind of where I'm at.
Brilliant, Vale. That was a phenomenal masterclass on how to think about diplopia. I don't really have anything to add. I think I would say you're ready to graduate, but you haven't even started residency yet. So whoever gets to recruit you is going to be very lucky in the coming years. Um, so this is great. Yeah. So first branch point is this monocular or binocular diplopia, as you said? Are the eyes misaligned such that the images projecting on the back of the retina are not where the brain is used to seeing them? So things look double. That, as you said, is a neurology problem. Or is the problem in one eye only some problem with the lens or otherwise that makes the image look double, or sometimes people even say triple, quadruple, something is kind of like a prism refracting the image in the eye. And that is, as you said, an ophthalmology problem, probably not what A brought for us today, or we will have a very short discussion. While we're on that point, Vale, how would you know from the history already, or if not from the exam, if the patient's not sure whether it's monocular or binocular diplopia?
Well, I think the sudden nature of this problem makes me think that, oh, you mean it, beyond that, like if the patient tells me that they cover one eye and it gets better, I
Yes.
usually would go monocular.
That one. Yeah, good. You guessed what I was thinking, or you've heard me talk about this before, knew what I would say next. Yeah. So if the patient says, when I cover one eye, it gets better, then it's a misalignment problem. And if they say, no, when I cover one eye, I still see double out of that eye, no, that's an ophthalmology problem. Great. And then you gave us all the components. I'll just highlight some of the anatomy you gave us. And, usually, as those of you who've been here on Morning Report before, know when we talk about pathways like the motor pathway, for example, which I think we talked about last time, we usually start from the top and work our way down. I find for the way I've gravitated towards teaching the extraocular movements somehow makes more sense to start from the bottom and build it back up. So Valeria made all these points already, but I'll sort of work backwards, mostly to highlight what she said and just to show you how I think about teaching this. So how are the eyes aligned? Well, there are 6 muscles that control each eye, right? 4 rectus muscles and 2 oblique muscles. So that's how the eyes move. And as Valeria told us, those muscles are innervated by cranial nerves 3, 4, and 6. Just for completeness, Valeria, which ones are innervated by which?
I believe so the sixth innervates the lateral rectus, and the fourth innervates the superior oblique, I believe, and then the rest the third.
Perfect. Okay, great. Yeah, great. So we have muscles, we have nerves, and Valeria pointed out that their interface there is a neuromuscular junction. And then those nerves arise from nuclei in the brainstem. Valeria told us perfectly, 3 and 4 in the midbrain, 6 is in the pons. Okay, so we have eyeballs controlled by muscles, controlled by nerves, and the nerves originate from nuclei. That term nucleus doesn't mean where the DNA and all that stuff is in neurology. It means where the cell bodies are, the gray matter cell bodies are in the brainstem that give rise to the axons that make the cranial nerves. Okay, and then one structure you didn't mention, Valeria, but I'm sure you thought of it. Now the eyes have to be aligned, right? So if I'm looking to the left, for example, my left cranial nerve 6 innervating my left lateral rectus has to be perfectly timed with my right cranial nerve 3 innervating my right medial rectus. How do those 2 nuclei in the left pons and the right midbrain know to talk to each other, Valeria? How do they communicate?
Through the medial lemniscus. No, I'm the MLF. I believe.
MLF, yeah.
Medial longitudinal fasciculus. Sorry.
Yes. You almost read my mind because people often confuse the word with medial lemniscus, and you sort of maybe I sent you some cross signals there since we've talked about this before, and you're probably reading my mind a little bit. Yeah, medial lemniscus is from the somatosensory pathways. This is the medial longitudinal fasciculus, which connects the 3rd nerve nucleus on one side and 6 on the other, and like an X. Actually, it's sort of a highway with exits from 8, 3, 4, and 6 to coordinate head movements and eye movements with each other. Okay. So you have cranial nerve nuclei that talk to each other across the midline through the MLF. You have cranial nerves, neuromuscular junction, and muscle. And then we have to decide where to look with our eye. Sometimes something happens and the eyes move automatically with attention. Those are sort of subconscious processing through the superior colliculus, thalamus, etc. But if I decide I want to look to the left, I originate that signal in my brain. So working upward. So my right frontal eye field is going to tell a structure in the pons called the PPRF, the paramedian pontine reticular formation. So my right brain, right frontal eye field tells my left pons, left PPRF, and the left PPRF, it was the horizontal gaze center to look to the left, tells the left 6 nerve nucleus to fire 6 and sends a signal across the midline through the MLF to tell the contralateral 3 to fire, to get my lateral rectus and medial rectus synced up by way of the neuromuscular junction. So this allows us, as Valeria said, to think of all the lesions that could cause ocular misalignment. A lesion of the FEF would not cause ocular misalignment, it would cause gaze deviation. That's another story, not for today. We would have a lesion of the PPRF, which is relatively uncommon. You'd also get a conjugate gaze deviation. The eyes are aligned, but can't move in one direction. But anywhere down in the hierarchy, if you have a cranial nerve injury, cranial nerve nucleus lesion, MLF lesion, neuromuscular junction lesion, muscle lesion, or something in the orbit preventing the eye from moving, those are all the ways to get diplopia. So there could be a brainstem lesion affecting a nucleus fascicle of the cranial nerve or MLF. There could be some type of skull base or meningeal process affecting the cranial nerves, or Guillain-Barré can affect the cranial nerves. For example, Miller-Fisher variant, something getting the cranial nerves themselves. You could pass through the cavernous sinus, as Valeria said, so things related to the sella, pituitary, other things that can happen in the cavernous sinus thrombosis, carotid cavernous fistula, etc. And then you get into the neuromuscular junction. So the eyes are very commonly affected in myasthenia, almost every case at presentation, not every, but almost every case. And then you have the muscles themselves, which can be affected by, for example, thyroid eye disease, structural lesions in the orbit itself. So that sort of gives us our anatomical landscape. So we know for diplopia, we're kind of brainstem and below. Brainstem, nerve, neuromuscular junction, muscle, orbit, as Valeria told us. Okay, so we have our localization piece of our equation. And then Valeria, you started to comment on the time course before you saw I was asking you to guess what I'm thinking question, and you know me well enough to guess what I'm thinking, and you guessed it. What are you doing with the sudden onset? Because even though we say localization and time course, the time course, as you were starting to allude to, I think, does make you think a little bit already about where the problem could be.
Yes, I think, well, usually sudden onset anything makes me think about vascular causes, and I think this applies to this as well. Like you mentioned, a stroke, for example, affecting the nuclei in the brainstem could lead to diplopia, but also I think, like for example, with third nerve palsy, we can also have like aneurysms that compress the nerves, and this could lead to onset diplopia if they are breaking. But I will also expect maybe headache in this case. Then other causes, well, I've seen patients with myasthenia or Guillain-Barré that they refer onset presentation of symptoms because they notice them and it kind of changes the way they their daily lives. So I would also consider that as a possibility, like rapidly progressive, but they notice it in an onset type of manner. So and they are emergencies, so I will keep that in mind as well.
Phenomenal. Yeah, that's exactly right. Yeah, Pearl from Marty Samuels, which you have independently come across on your own. He used to say diplopia is always acute because your eyes are sort of aligned enough to fuse the image until they're not, and you notice. So in some ways, it's sort of always acute. But someone could tell you, but it keeps getting worse and worse, or something like that. Right, so a stroke in the brainstem, have to be a pretty tiny stroke to cause just diplopia, though you can get just a stroke of the MLF. You can get infarction of the ocular motor nerves like 3, 4, or 6, sometimes called a diabetic cranial nerve palsy, although you don't have to have diabetes. Really, any vascular risk factors could do that. That's a very common cause of an acute 6th or an acute 3rd. More commonly, these are pupil-sparing 3rds, which we'll get into if that's relevant here. Something in the cavernous sinus, that would be that acute, maybe cavernous sinus thrombosis, maybe carotid cavernous fistula, maybe aneurysm rupture there. As you said, probably we'd see a lot more going on here, though we don't know the whole history if there was aneurysm rupture. Then even myasthenia, someone might not notice diplopia until they do, or it's fluctuating and they kind of think there's something in their eye or it's their glasses or something like that. So I think that's not out of the question. But yeah, first pass, if you told me this age, this symptom, this acuity, probably common things being common, I would think of a microvascular 3rd or 6th or 4th, depending on which muscles are affected, or a very small stroke in the brainstem. Great. Okay. Can we hear some more history, A?
Sure. Wow, such a brilliant discussion and fairly as always. So for the other history, he is a 73-year-old male and present with sudden onset of diplopia for 1 day. It is constant. There is no fatigability or ptosis, and there is no blur vision. There was no past episode of diplopia like this before, and no associated headache or seizure. There is also no weakness, tingling or numbness, and bowel bladder is also normal. There is no associated weight loss, and he has normal activity of active living. And in other systemic review, it is irrelevant or normal. He has a history of hypertension and hyperlipidemia. So he was taking medicine for hypertension, amlodipine, but he just stopped taking atorvastatin. And the family history is prominent for his father. He has a history of stroke. And then other social history, he is non-alcoholic or no history of smoking and no allergy.
Great. Thanks, A. Brilliantly presented as always. Vale, any other questions about the history you're curious about or want to clarify? I had a few questions, but you go first.
Did he have any weakness, like in his extremities?
No weakness.
Yeah, and what were
Okay.
you thinking about there by asking that?
Like for example, Guillain-Barré or brainstem also could lead to multiple things. But I
Yeah.
guess we need to confirm with exam.
Yeah, very good. Other questions you had?
Um, no, I think I want to applaud A because her presentation in the HPI makes me think about what she was thinking as well, and I think we check the same boxes.
Yeah, great. A, you said there was no headache. Was there any pain around the eye or with eye movement or anything like that?
No pain around the eye or no headache.
Yeah, you know why I'm asking that, A or Vale, why I was interested in pain?
Were you thinking about giant cell arteritis?
That's one thing I was thinking about. Yeah, we think of GCA with headache, visual blurriness or visual loss, jaw claudication, scalp tenderness, sometimes constitutional symptoms, but it can cause ocular motor cranial neuropathy. So you might notice I'm using that term ocular motor. That sort of refers to 3, 4, and 6 as opposed to oculomotor for 3 by itself. I've never seen it do that. Presumably it's some type of nerve infarction from the small vessel vasculitis, I guess. I don't know. I've looked for GCA all the time. Anytime sort of an older patient has something eye or something head pain, I send ESR and CRP. I've never actually made a diagnosis of GCA. I think it's very rare without jaw claudication, scalp tenderness, constitutional symptoms, or the primary care doctor's just catching it and we never see it in neurology. But it's part of my workup for new headache or visual stuff and people over 60. I've never diagnosed a case. And also the microvascular 6th or 3rd that we've talked about often does have pain, actually. The patient can have pain kind of around the eye. Don't have to, but you sometimes see that. You can see that. And then just the other question, A, was the patient able to say whether the images were side by side or on top of each other or diagonal, which also kind of helps us think about if this horizontal diplopia, vertical diplopia, or yeah.
Yes, the images are side by side.
Side by side. Okay, so horizontal diplopia, which we've already sort of laid out the landscape for. I didn't mention vertical diplopia in there because it's its whole own complicated thing to talk about. So I didn't want to get into it unless it was relevant here. But okay, so we're squarely in the field of a horizontal diplopia. So Valeria, we're going to see the exam here. If it's horizontal diplopia, what are the possible, what are the ways, what are the possibilities for how to get horizontal diplopia? What has to not work for you to get horizontal diplopia? What are all the possibilities? So we can then go to our exam with the hypothesis or the hypotheses and then figure out where the problem is.
Yeah, I would think in terms of the movements, like the 6 is not working, or the third, um, and well, the one that I would think, okay, maybe this is not it, the fourth, because that would have to be down. Then also, well, and with that, it could be anything from the way the nerve is going out of the socket, the neuromuscular junction, the muscle itself, and then the nerve, and going all the way to the, well, I guess the lack of any other symptoms makes me think less of the brainstem and more about something in the periphery. I also wanted to shout out Ethan in the chat mentioned the change in the day, and I think fatigability is another question that is really important to ask, thinking about neuromuscular junction disorders in this patient. But yeah, I'm not sure if I answered your question because
Yeah.
I've never thought about vertical diplopia actually, which is something I need to look up to.
Yeah. Yeah. So for horizontal, oops, excuse me. For horizontal, right, what movements do we need? We need lateral rectus on one side and medial rectus on the other side. So there could be a problem with one lateral rectus or the other medial rectus, or with thyroid eye disease, it's a little tricky. There could be restriction in one of the opposite movements. So if you can't abduct, look to the left on the left, you could have left lateral rectus problem or left medial rectus constriction that's kind of impeding the movement. But okay, barring sort of structural things like that, either we have the left lateral rectus or the right medial rectus. Let's presume it's it's left, just for the sake of argument. It might end up being right, then we get to review both. Okay, let's say the patient has horizontal diplopia when they look to the left. They've noticed that. So it could either be left lateral rectus or right medial rectus, left 6 or right partial 3, or MLF, right? So that's sort of our playing field. So if it's horizontal diplopia to the right, Valeria, can you fill in the blanks? If the patient has horizontal diplopia to the right, what are the possibilities?
That to the right, meaning that you do this.
They look
Okay,
to
so
the horizontal double vision. What are my possibilities the way I just spelled them out for the left? Or if you're able
it
to
would
work.
be that the left medial rectus is not working,
Or
or um, or the 6 is stuck. The lateral.
yeah, so if I can't look, if I have diplopia to the right, we don't know yet what the eyes look like. Either it's right lateral rectus, left medial rectus, right 6, left 3, or MLF, right? You see what I mean?
Yes.
Somewhere along the way of looking to the right. So it's either from the back. If I'm having diplopia when I look to the right, either my right 6, my left 3, my right lateral rectus, my left medial rectus, or the MLF, right? So that sort of gives us our playing field. Sometimes you can see the patient while you're talking with them, the eyes are totally misaligned and you're done. Sometimes the patient has diplopia and the eyes are just off enough that the patient has double vision, but you can't really see an obvious eye movement abnormality. And then you get into fancy stuff like the cover-uncover test and the Maddox rod, which we can talk about if that's relevant. You're doing a great job, Valeria. The neuro-ophthalmology is like the higher math of the neurology. I call it like the calculus of neurology. Most of what we do, it's kind of, you draw the map, you figure out where something crosses. That's kind of arithmetic, but eye movement stuff is like, I think of it like calculus for us. There's a lot of things being backward and upside down. And so this gets into really difficult territory, and you're doing a great job. So yeah, just remember the eye can move in all these cardinal directions. And if it's a horizontal problem, you're in the field of medial or lateral rectus 6-3 or MLF, and then it's which direction is the problem. And if you can't see it, at least it's one of these things, and then you can use some of these other bedside maneuvers to sort it out. Out of all of those, this is acute. And there's some other factors in there, even though we haven't even seen what the eye movements are yet. Is there one that would jump out to you given these possibilities? Could it be a lateral rectus problem on one side, a medial rectus problem on one side, a 6 problem on one side, a 3 problem on the other side, or an MLF lesion? Just that this is something that happened acutely. Does that help you narrow those down at all?
Well, I think considering the age, I think if this was a younger female patient, I will think about something like intraocular, like IOP. You
Yeah,
know, the MLF is
yeah,
affected, so there's
yeah. We call it INO, but I know what you mean. Yeah, internuclear
I
ophthalmoplegia.
know intraocular ophthalmoplegia. Yeah, sorry.
No, no.
Um,
Yeah.
that like a manifestation of an autoimmune disorder like MS. But given this patient is 73, I would think about maybe something ischemic, and I think the third nerve is a favorite of microvascular incidents. So that's kind of that's my best guess.
Yeah, with the time course, the age, and diplopia, I would certainly think of a microvascular etiology as well. You pick 3. Our choices would be 3 or 6. Again, we'll see in a second, but this is just for the academic exercise and to practice some calculus here. Why did you pick 3 as opposed to 6? Well, let me put it this way. I would pick 6. So why do you think that is?
I actually don't know. I guess I just like maybe I'm biased and I have seen more 3s than
Yeah.
6.
That's fair. Yeah. Remember, as you told us earlier, 3 does a lot of stuff. 3 doesn't just do the medial rectus. It does superior rectus, inferior oblique, the lid. So to get a partial third affecting the fascicle, the fibers of the nerve just to the medial rectus, that's a little hard to imagine. If this is truly, I mean, we'll see on the exam, maybe the patient has said horizontal diplopia, maybe they have multiple eye movement abnormalities. But if it's truly a pure horizontal diplopia in one direction, and that's it, and the patient can look up, down, no ptosis, no pupillary abnormality, though you don't always see that with a third. It's hard to imagine that just one tiny strand of, I mean, that nerve is the size of a piece of spaghetti. So one microfiber of that spaghetti is out and the rest is okay. A little bit of a stretch, probably. So yeah, I would be thinking of a microvascular 6th. I would say if it is a 6th, you couldn't get a stroke just causing that because the 7th nerve fascicle wraps around the 6th nerve nucleus. Usually you get 6 and 7 as a pair if you get a lesion in the brainstem. But a few weeks ago, we had a patient who had sudden onset diplopia. We thought it was a classic microvascular 6. He was already actually recovering in the emergency room. You could just barely see it, but someone who had seen him earlier was pretty convinced there was a 6th on one side. But the emergency room got an MRI, and he had the world's tiniest little dot of a stroke in the 6th nerve fascicle. So never say never. Probably we would have thought this was microvascular and not gotten an image, but I guess some of those patients actually have the world's smallest stroke. Okay, that was just for fun. We'll see the eye movements, but yeah, little less likely to get a partial third, although maybe there is a full third here and just the patient is talking about horizontal diplopia. Okay, so we're very interested in the exam. If it's all normal except the eye movements, you can tell us that just for time's sake and focus on the eye movements. If there's other stuff, of course, tell us that too.
Yes, so the neuro exam is there's only abnormality in the eye movement, but we can see there is like high blood pressure, 155/90, and the others are quite normal. So on neuro exam, like mental status, he is alert, oriented, and on cranial nerve examination, there is no ptosis, so there is no anosmia, and then blur vision. But on extraocular movements, there is double vision, and it goes away when closing on either eye. And on extraocular movement, on the left lateral gaze, both eyes just stay in the midline. And on the right lateral gaze, the left eye stay in the midline, and the right eye can do abduction, abduction, but not adduction, adduction. And there was nystagmus on abduction. And but the conjugate eye movement is normal. The pupils are reactive and small and reactive to light. There is no facial weakness or numbness on the face, and the tongue movement is also normal and intact, and the shoulder shrug is also normal. The other motor examination, all the limbs are on full strength, like 5 by 5. There is no sensory loss, and reflexes are like 1+, and the plantar is downgoing.
Okay, I know the scribe is still catching up with all the things you tested and described on the exam A, just to make sure we've got this. On left lateral gaze, attempted left lateral gaze, there's no movement of the eyes. And on attempted right lateral gaze, the right eye abducts with nystagmus, but the left eye does not move. Is that correct?
Yes, it's correct.
And is there any facial weakness?
No facial weakness.
No facial weakness. Okay, Valeria, I mentioned that neuro-ophthalmology is calculus, and I think A wanted us to do some higher order calculus today because she, as she always does, brought us sort of a special thing today. Do you recognize this pattern, Valeria? Okay, if you do not, I probably learned this as a 3rd or 4th year resident. If not, what can you sort out here to try to make sense of it? Because we talked about this could be a medial rectus on one side, lateral rectus on, et cetera, but obviously there's a lot more going on here. How are you thinking about this?
Yes, I believe I do recognize this pattern, but I'm having trouble localizing it. I remember well, I learned it from you, and Gabby, I think, has a great infographic on it in her Twitter. But basically, okay, so I have my little graph here because I cannot do that. But okay, so when we go to the left, there's no movement. So there's and then we go to the right, the 6th nerve in the right works well, but no. So it means that both the 6th and the nerve and the 3rd, sorry, are compromised in the left eye, and in the right only the 3rd. So that reminds me of I'm not sure actually, but the 1.5 syndrome. I remember Gabby talked about that in her case a while back, and that idea that 1.5 is it's compromised in lateral gaze. That's kind of what I was getting at.
Brilliant. Very impressive that you not only know what this is, but you're able to recognize it there. This is 1.5 syndrome. So how this works, yeah, we have to remember whenever we think of the eyes moving, we think of 6 and 3, but we have to remember some of the brainstem structures here. So let's do the easier side. The patient tries to look to the right, and the right eye abducts. So we know right lateral rectus is working, and right 6th nerve is working, which means right 6th nerve nucleus is working. However, what's supposed to happen when that right eye goes to the right, the left eye is supposed to adduct, and that does not happen. So what lesion explains what's happening when the patient looks to the right, Valeria? So the neuro-ophthalmology rotation, and sorry to ask you a question and start talking again. Just
Sorry.
for all of you playing along here on Holiday Edition, I did a neuro-ophthalmology elective in medical school, and whenever they were resident or fellow was presenting to the attending, he was doing this with his hands. And so I like to pick that up. So, okay, looking to the right, this happens, but this does not happen. So where's the lesion explaining the problem on rightward gaze?
Yeah, how I think about it is like the 6 is telling the 3rd of the other side, move with me, but the 3rd is not getting the message through the MLF. So the 6 is moving and the 3rd is not moving in the left side.
Okay, and just for gourmet neuro-ophthalmology localization, is that the right MLF or the left MLF? The labeling is a little bit confusing because it spends some time on both sides, but this will be important for understanding the whole picture here.
I believe it's the left, because how I remember is that all MLF things are kind of, I always remember the 3rd, the 3rd, the 3rd. Like that's kind of my North Star, because
Okay.
otherwise I'll get very, I don't know if I'm wrong, but
No, you're totally right. You're totally right. Yeah, the MLF from 6 to 3 crosses very, very soon after it leaves 6. So it spends most of its time on the side of the third nerve nucleus to which it is destined, as opposed to the 6th nerve nucleus from which it originates. Okay, so the patient, when they try to look to the right, the left eye doesn't move. A gave us that abducting nystagmus. As you said, it's like the right eye saying, come on, try, please come with me, and it won't. So we have a lesion in the left MLF. Now the patient can't look to the left at all. That's a conjugate gaze problem, not a diplopia, disconjugate gaze kind of problem. So how do we look to the left? We need the right frontal eye field to send the eyes to the left. If we had a brain lesion here, we'd have all kinds of other problems, which we don't, so that's probably not the answer. And do you know, Valeria, do you remember from discussing this earlier, the right FEF communicates with which structure in the brainstem to tell the eyes to look left? There's one step before the 6th nerve nucleus. It's okay if you don't know, yeah.
There are so many like acronyms when it comes to like the PPRF, something like that. I don't remember what
Right.
it stands
Yeah,
for.
you do remember. You do remember PPRF, paramedian pontine reticular formation. That's the brainstem horizontal gaze center. Brainstem, almost everything heading out to the cranial nerves is ipsilateral, except for that crosses, that there's no real clinical relevance to that I'm aware of. So the PPRF on the left talks to the left 6 nerve nucleus, which then does the left 6 MLF right 3. You might say, why doesn't it just plug into the left 6 nerve nucleus and skip that PPRF step? Well, usually we want to move the eyes conjugately, but not always. And actually, when we look into the distance, the eyes diverge a little bit. So you want to be able to do things with the 6 nerve nucleus that don't automatically activate the contralateral 3. So the PPRF is the horizontal gaze center that tells 6 to do 6 plus 3. But there's some divergence center. I don't know its name or where it is. Presumably it's in the pons near the 6 nerve nuclei that tells the 6ths to pull the eyes a little bit apart and expand one's gaze into the infinite. Okay, so we have a problem in the left MLF and the left 6 nerve nucleus or left PPRF. We can't really distinguish those to my knowledge. And those are all really close to each other. And this is called 1.5 syndrome because you have a full conjugate gaze palsy on one side, can't look to the left, and half of a conjugate gaze palsy on the other side. You can look to the right with one eye, not the other eye. Do you know who described this syndrome, Valeria? This is channeling my beloved mentor, Marty Samuels, who knew the history of all of these things, but it's a kind of fun answer. Or do you know, A?
I have no idea.
Do you know, A, who described 1.5 syndrome?
Yeah, it's like Dr. Fisher or...
Yeah, it was C. Miller-Fisher of Miller-Fisher syndrome. Miller-Fisher described so much of what we talk about in neurology. And Miller-Fisher was a mentor to Marty Samuels, was one of his professors. So got to hear lots of stories about Miller-Fisher. But yeah, in a paper called something like A Few Neuro-Ophthalmologic Observations, this is one of many things that someone who spent a lot of time at the bedside documenting very scrupulously everything he saw noticed that this can happen. So Miller-Fisher did not just coin Miller-Fisher syndrome, but 1.5 syndrome. And so much of what we understand about stroke and neurology comes from Miller-Fisher. And apparently Marty said that Miller-Fisher always told them when they discovered a sign that, or a syndrome, part of what was important was giving it a clever name that people will remember. And 1.5 syndrome is a very clever name. The reason I asked about facial weakness is because that MLF and PPRF are right near the 7th nerve nucleus. And if you get a 1.5 syndrome plus a 7, it's been cleverly labeled the 8.5 syndrome because it's 1.5 plus 8 plus 7, sorry, to get to 8.5 to go along with our mathematical theme. Okay, so we have a lesion of the left MLF and left PPRF or left 6 nerve nucleus. Just to remind everyone, Valeria, where does all that live? Where specifically in the brainstem?
The pons.
Yes, and can you be even more specific, as in dorsal, ventral?
Yes, so we are talking about the 6th. Okay, so the middle part of the pons.
Yep, and anterior or posterior? Where do the cranial nerve nuclei live? Do you know?
I don't know why I want to say dorsal, but I'm actually not sure.
You want to say it because you're exactly right. Yeah, the cranial nerve nuclei live in the dorsal brainstem and send the fascicles out anteriorly, except for that comes out the back. And then anterior is where you have the long tracks, basically. So the brainstem nuclei are posterior or dorsal, and as you said, the motor ones are at the midline, so 3, 4, 6, 12, and slightly more lateral are the bronchial motor 5, 7, 9, 10, and then most lateral are the sensory, special sensory 5 and 8. Okay, so we have a 1.5 syndrome. As Valeria said, we are in the left dorsal pons. How beautiful is neurology that just reading all this text on a page and discussing it, we can localize in about a 1 centimeter radius where the problem is. So much so that even if this patient had an MRI and it was normal, because the slice thickness is such that we missed a small area of diffusion restriction, we would 100% say, nope, there is a lesion there. There's no other possibility. What do you think caused this, Valeria? Now coming back to the time course.
Thinking about a very tiny stroke, like you mentioned the case, or maybe, well, then again, this patient does not fit a demographic, but maybe like that demyelinating lesion could be very specifically there, but less likely here. I mean, a stroke or maybe an ABM compressing this site specifically, but then again, it would not be sudden. So yeah, I'm putting my coin down in a stroke.
Yeah, I will add a coin with you. Yeah, this was most likely a stroke. This was sudden onset, dorsal pontine lesion. Hard to think of anything else that would cause this. So yeah, here sometimes the diagnosis part is the hard part. Sometimes the localization part is the hard part. Here, our heavy lifting was more on the localization side. Once you got there, this was fast. It was in the brain. Probably was a stroke. You mentioned demyelinating lesions can definitely cause INO from affecting the MLF. That's very common on step 1, right? I don't know if you could get 1.5. I think you do need to get the gray matter structure, which in principle MS shouldn't affect, but maybe if you got enough white matter around it. I don't know if you can get that from MS. I've never seen it. Maybe you could. Yeah, but I agree. Demographic and time course here. This was a stroke, and the fun part was the localization, and the diagnosis probably pretty easy once we got there. Okay, A, what were you and your team thinking? And then did Valeria and I follow your breadcrumb trail to the correct location?
Yeah, you are like excellent. This is all what we are thinking. So and also the localization process is the fun thing in neurology, and we learn a lot like neuroanatomy from both of you. And I'm so grateful for that. So yeah, this is so you all get a diagnosis 1.5 syndrome. And so this is a case from VMR, and just in our clinic, mostly the patients just got like 1 or 2 days after a stroke, and we just do CD or MRI, and we just did MRI and saw a very small lacunar infarct in the dorsal horns. I wish I could show the images, but I just couldn't do that. And yeah, so we do some basic labs, and apparently like hemogram, others are normal. He just have hyperlipidemia. He also stopped just taking atorvastatin. And so we just give antiplatelets and other statins and for retention control. Yeah, that is all I have for today.
Well, you brought us a beautiful Christmas present to unwrap here, which we appreciate. And I was going to try to extend the Christmas metaphor to Valeria's excellent discussion, but I'm nothing came up. Okay, one little thing. A, you called this a lacunar infarct. Tell us why you called it that.
So it is very small infarcts in the dorsal pons, and
based on the size. Yeah. As my residents at UCSF know, I sometimes question this idea of lacunar. I mean, I believe that lacunar infarcts exist, these small vessel strokes due to lipohyalinosis of small arteries in patients with chronic hypertension, specifically, and other vascular risk factors. But the implication usually when people say it's lacunar is that it was caused by hypertension, and some practitioners will say then we don't really need to do an embolic workup. And I take a little bit of, I question that logic a little bit, not based on any data, but just sort of more in principle that you could get a small embolism into a small vessel, right? There's nothing that proves on the scan that because the stroke is small, the mechanism is lacunar. Certainly cortical infarcts or multifocal cortical infarcts or multifocal infarcts, people would say, sounds more embolic, appears more embolic. But, in the pons, the sort of more anterior kind of wedge-shaped infarcts are thought to be in that kind of hypertensive etiology, those kind of penetrating vessels that come off at 90-degree angles from the basilar artery, these pontine perforators. But way back in the dorsal pons, there are those tiny dots. I often wonder if those are actually embolic in nature, because if you imagine those small vessels, a lot of the atherosclerosis is at branch points. So you have the basilar and you have the tiny perforators coming off, and they kind of occlude at the origin. But to think that they just got kind of atherosclerosed and kind of stopped feeding the brain territory at the very distal end. When I see a very kind of distal end arterial type of stroke, makes me think more of embolism. So yeah, some of my residents who are interested in stroke, we debate this. They say it's lacunar. We don't need to do an embolic workup. And I say, but could it be a really small embolism? And this, in a case of a pontine perforator, which maybe not, may be the case here, but not always. They say, well, the embolism would have to come up and then make a right angle. That doesn't make sense. And, just to be provocative, I say, yeah, a lot of things don't make sense. And operationally, it's not much harm to the patient to do an embolic workup if the embolism is on the table. And that's really the only thing that would significantly change the management here. For any stroke, this patient would get aspirin and a statin, any stroke in patient with vascular risk factors of this age. But if you found atrial fibrillation, or an embolic source, that would really change how you think about this patient's management with anticoagulation or a search for the source of embolism. So just to put that out there, there's an article, this is again something Marty sent around, I forget the person's name, but who wrote this series of articles called Neuromythology, about sort of concepts we talk about that maybe when you look at the primary data, maybe not as strong as we think. And one is called Holy, 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 and it's spelled WHOLLY, HOLY, and then HOLEY. So holy, like the whole of something, and then holy, like, religious holiness, and then like the whole, like a hole in something for Lacunar. And it talks about how this was sort of a pathologic concept in the autopsy table that kind of took on a life of its own in terms of how it's applied clinically. Landau is the name, William Landau. It's from before my time, but a paper Marty liked to send around. So lots of memories of things Marty would say about this type of case and about Miller-Fisher. But yeah, look up Holy, 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 or Valeria and A, email me and I'll dig up this paper for you. It's kind of a fun take on where this concept comes from and how strongly we should be applying it in different contexts. But yeah, I often like to think smallest stroke could be from the world's smallest embolism. Doesn't mean it was a lacunar. And that area of the dorsal pons, I'm not sure, maybe if it's fed by the very distal end of that penetrating vessel or from one of the branches from the circumferential arteries, AICA, PICA, that kind of loop around and then have small penetrating arteries. But I would not exclude embolism. Yeah. What do you think, A?
Yeah, you are right. I think it is not like lacunar infarct, just like small infarct in the dorsal pons. And yeah, just at the very distal side, I think.
Yeah, I think it may come off. I don't know actually the anatomy. I think it may come off the circumferential vessel, not dorsally. When you think about it, eye movements are so important, right, to survival, just evolutionarily. You probably wouldn't want it fed by the distal end of some tiny artery. Probably it's, but I don't actually know. But I think those come off the penetrating artery. So I would probably work this patient up for embolism if you had the resources and just to be a little careful around over applying this term lacunar. And check out this Holy, Holy, Holy paper.
Yeah, to To your point, Aaron, I just wanted to say that I actually rotated with a vascular neurologist once, and he always mentioned this, that often people would say lacunar, and to your point, it is, I think one of the criteria as well is that it's only one, to kind of qualify it as lacunar, because even if you have, like, if you even have two very small strokes, you should think about embolic causes and not call it lacunar anymore. At least that's what he
Oh, yeah.
thought.
For sure. Yeah, it would be statistically unlikely to have multiple lacunar infarcts at the same time, right? But even when you have one, the really classic ones are the deep subcortical, in the internal capsule causing pure motor hemiparesis. These were also all described by Fisher, by the way. All these lacunar syndromes. There's a paper with like 30 of them, but the most common ones are pure motor from the capsule, pure sensory, pure hemisensory, with VPL, VPM of the thalamus, ataxic hemiparesis from either the subcortical white matter getting corticospinal and corticopontocerebellar, or anterior pons getting corticospinal and corticopontocerebellar, dysarthria, clumsy hand. Those are the four people talk about most, but he has dozens of them in one of these papers. But yeah, when you have one of those deep kind of little circle deep in the brainstem, I'm sorry, deep in the subcortical white matter or gray matter, yeah, I'm pretty comfortable calling those lacunes. I will wonder, how can we exclude just on principle that it couldn't have been embolism? And then the sort of wedge in the anterior brainstem, I think, sort of lacunar type of pathology. But, it's not harm to the patient to go looking for an embolic source. And again, that would be management changing. And atrial fibrillation is pretty common in this age group. Okay, well, thank you again, for this Christmas gift of a really fun neuro-ophthalmology case. We got to work through some basic neuro-ophthalmology and then some gourmet neuro-ophthalmology with 1.5 syndrome. Anything else you wanted to teach us today about this, A?
Yeah, can I just share the screen? I'm
Please.
prepare some images to share. Okay, so this is the one we are talking right now. So this is the lesion where we have PPRF, which controls the same ciscranial nerve, so lateral radius palsy, and then the medial longitudinal fasciculus control the same third nerve, and to the other opposite third nerve. So this is kind of like when you look at the right case, it has abduction, only abduction, and then the left eye couldn't do both abduction or adduction. So this is where 1.5 lesion is, and so we can do some sort of like games here. It's kind of fun. So this is where 1.5 lesion, and as Aaron said, there's like cranial nerve 7s going around. So this is 1.5, and with 7, it's called 8.5. For this, like these images, there is 1.5, and also there is corticospinal tract lesion involved. So like there is hemiplegia, one side weakness, and sometimes so it is with 8.5, 1.5 and 7, so 8.5, and half of the body. So 8.5 and half combined, sometimes called 9 syndrome. And sometimes like cerebellar petechiasis, so like one side ataxia, or ipsilateral or contralateral ataxia. So it's also called 9 syndrome with 1.5, including 7, and half of the body ataxia. So these are the 9 syndrome. And for this one, image G, you have 1.5 and 7, and it also have trigeminal nucleus 5. So it's all combined 13.5 syndrome. Mostly they are just like, there's only one case around like lymphoma, like spreading from the other side and then to the brain and affecting all of these. And most of these also could be like, yes, multiple sclerosis, and also like that infarct. But this one case is like kind of lymphoma. And then this is sometimes it has bilateral 7 nerve and ipsilateral 1.5 and 7. So all combined 1.5 plus 7 plus 7, 15.5. And the other one, image I, we have 1.5 and then 7 and also 8 cochlear nerve. 8 nerve is also involved. So all together 1.5 plus 7 plus 8, so 16.5. I hope you all enjoy.
Oh,
the
our stockings are full of neuro-ophthalmological pearls. I knew about 8.5. I think I saw someone describe 13.5 in a paper. I didn't know about all these fun, as you call them, some games here. Yeah, I always call this higher math, but here we're really doing some math. Okay, well, if you're loving this conversation, neurology is for you. If you are rolling your eyes and waiting for the next VMR to start and thinking these folks are such nerds, then well, we thank you for joining us anyway. This was a great case. Hey, thanks for that teaching at the end. I hadn't heard about 15.5 syndrome, and really brilliant discussion, Blair. This was a hard case, and you built it up from the basics to the most complex, and you recognized something that probably few people know about outside neurology. And we got to invoke the great C. Miller Fisher and his pupil, the late great Marty Samuels, who was my teacher. So nice to honor their memories and contributions to neurology in our holiday celebration as well. I hope you all have a wonderful holiday. We're going to do this again next week, the New Year's Eve day edition, and then we'll take a little break because I have a lot of service in January and February. But thanks again, A. Thanks again, Valeria, and enjoy the next VMR starting in a few minutes. Happy holidays, everyone.
Happy holidays.
holidays.
Thank you.
Thank you.